Hey everyone, welcome back. Today we are tackling something that is deeply complex and frankly heartbreaking hurdle in reproductive medicine, recurrent implantation failure or RIF for short. Look, going through IVF takes an immense toll, emotionally, physically, and financially too. When you transfer what looks like a perfectly good embryo and it just does not give you result, that setbacks is completely devastating. But as we are going to see today, it is not just a matter of bad luck. It's a highly intricate but completely solvable medical puzzle. Okay, let's dive into this. When multiple embryo transfer fails, so it's incredibly common for patients to just blame themselves, right? To feel that your body is fundamentally failing you. But I need you to set this aside. Actually, scratch that. Throw this thought completely away. RIF is a clinical phenomenon when high quality embryos fail to implant. It's just a signal. It means there is a missing piece of evidence in your specific reproductive landscape. We just have to go in and find it. First up, we need to understand how the medical community even defined this issue because it actually changed a tone recently. The old definition was very rigid. It usually just meant a fixed number of failed cycles, say like 3 attempts with good embryos, regardless of the age and the embryo genetics. But the modern metrics, it's much more known. Supported by the organizations like ESHRE, it looks at an evolving probability threshold. So, for example, if you transfer two genetically tested euploid embryo, meaning they have the normal number of chromosomes and implantation failed, well, then we may consider this as a RIF in factors in modern advancement like pre-implantation genetic testing and maternal age aiming for cumulative implantation probability of at least 60% before waving that red line. So, moving into our first section, uncovering the root causes. This is where the detective work really begins. Once that red flag is raised, we enter the investigation phase. A rigorous evaluation absolutely must happen before any further treatment begins. To keep things from getting totally overwhelming, we can break all this scientific data into four clear suspect categories. First, we have an embryonic factor like chromosomal abnormalities or aneuploidy. Second are the uterine factors. Think physical polyps, infections, or the adhesions. Thirdly, immunological factors. When autoimmune bodies or cytokine imbalances might be throwing the wrench in the works. The fourth, it means honestly get overlooked way too often. That is the paternal factor like sperm DNA fragmentation. By categorizing the data like this, it's basically like building a structured map of exactly where things can go wrong. Moving on to the section 2 embryo-endometrial connection. Let's look at this dynamic relationship. Now, what's really interesting about this slide is how it frames the interplay between the embryo and the lining, that's the endometrium. It reframes our entire understanding. See, for the longest time, we thought that the endometrium is just a passive landing pad, but it's not. It's an active biosensor. Think of it almost like a biological bouncer at a club, actively deciding who gets in. A healthy endometrium will actively accept the high quality embryo, but crucially, it will also actively reject a poor quality embryo. So, implantation is just not one sided failure. It's an ongoing dynamic conversation between the embryo's competence and the endometrium cell. That brings us to the section 3 investigating the uterine environment and identifying those key disruptors. So, knowing the endometrium is an active sensor, what happens when it malfunctions? Well, we have to shift our focus to the specific condition inside the uterus that can disrupt this delicate balance. There are several key uterine disruptors that can essentially scramble the biosensor signals. We are looking at things like chronic endometriosis, chronic endometritis, which is persistent, often totally silent infection. We are looking at anatomical anomalies like fibroids, polyps, which literally can block the physically the implantation. And then there is a issue of a thin endometrium which simply does not provide enough bed, the vascular support. And finally, emerging research is pointing very heavily to endometrial microbiomes, the balance of bacteria in the uterus. What absolutely vital to remember here is that specific issues require highly specific mix fixes. For example, if you have a chronic endometritis, you need targeted antibiotics. You do not need a generalized heavy handed immunosuppressants. All right, section 4, beyond the uterus. Let's talk about paternal and lifestyle factors. You see, the investigation cannot just stop at the female reproductive tract. We have to look at the factors affecting the raw materials before an embryo is even formed. These are what I call the quiet saboteurs. On the male side, listen to this. If a standard analysis of the semen looks perfectly normal, issues like sperm DNA fragmentation can severely compromise early embryo development and straight up lead to RIF. Then there are lifestyle factors for both the partners, things like elevated BMI, chronic stress, smoking, even e cigarettes and alcohol consumption have been shown to really impact overall fertility. And of course, advanced maternal age naturally decreases cellular energy and increases the chance of chromosomal error. If left unchecked, these external factors are constantly undermining your implantation potential, which leads us perfectly into section 5, diagnosing the exact issue through a methodical workup. We know the suspects, right? So, how do we actually gather the evidence? We move to formal diagnostic workup to solve your individual case. Doing this methodically, step by step, is exactly what prevents the stress and the massive expense of completely unnecessary interventions. Step 1 is often PGTA or pre implantation genetic testing, just to rule out embryo genetics as the culprit. Step 2 is a hysteroscopy that's directly visualizing the uterine cavity to find or remove the pathologies. And step 3 involves specific biopsies like CD138 count, which is specifically looking for the markers of chronic inflammation or the microbiome sequencing to check for those silent infections we talked about. This highly logical pathway ensures we are treating the actual problem and not just guessing in the dark. Let's head into section 6, personalized targeted strategies. This is where we get into hot medicine. Once we finally have for our diagnostic evidence, we enter into the management phase. And honestly, this is where things get truly hopeful because now we can prescribe a customized solution. For way too long, the approach of RIF has just been trial and error. Blindly stacking costly IVF add on and just hoping one of them will work magically is absolutely not true. What makes sense is just like high fashion, no two patients are exactly the same. So, no two treatment plans should be exactly the same either. It's all about data driven, highly tailored management designed specifically for the individual sitting right in front of you, based entirely on the exact clues uncovered in their workup. So, the crucial point is matching the evidence to the intervention. If the issue turns out to be embryonic, we transfer PGTA tested euploid blastocyst. If the hysteroscopy showing chronic endometritis, we'll give a targeted antibiotic. Simple as that. For a persistently thin endometrium, localized regenerative treatments like intrauterine plasma or PRP are showing some absolute incredible promises in latest studies. And throughout this whole process, we make sure to prioritize customized hormonal optimization. Every single thing we do has a distinct purpose. And finally, in section 7, future horizons, let's look at the cellular energy. As we continue to refine these treatments, science is also looking ahead specifically for the aging patients. And this brilliantly illustrates the future focus is of cellular energy. And let's talk about NAD+. It's a vital molecule found in literally every cell that supports the mitochondrial function and the health of the oocyte as well. That is, you can think about mitochondria as the battery pack for an egg. As women age, NAD plus levels naturally declines. It means simply put the egg's battery has been draining. Recent preclinical studies on mice have shown beautiful things. Boosting NAD plus levels actually restores the mitochondrial health, delays the age related ovarian decline, and importantly, normalizes chromosomal alignment, which leads to fewer errors. Now, we are still waiting on human clinical trials for oral supplementation or the injectable. But it is a fascinating look at how we might eventually support the egg quality right at the cellular level. I want to bring this all together with a quote saying, today we need to see when implantation repeatedly fail, solution is not to stack one ad on the other. It is to slow down, investigate properly, go through this right now if you want to hear this. You deserve the proper rigorous investigation. Which brings us to our final thought for the day. You know that recurrent implantation failure is a multi-layer puzzle. It involves the embryo, the uterus, the immune system, and the lifestyle factors. You know that the tools that exist actually solve it. Armed with this knowledge, how you will advocate your own personalized data driven care plan to your specialist. Seriously, don't settle for a guesswork. Demand the detective work. Until next time, keep learning and keep asking the right questions.